Bismillahirrahmanirrahim. My talk is about the urethral trauma, EUA guidelines presented by Dr. Jawan and PJ Urology Secretary. First, we will talk about the trauma, urethral trauma in general, definition and epidemiology. Trauma is defined as a physical injury or a wound to living tissue caused by extrinsic agent. Trauma is the sixth leading cause of death worldwide, accounting for 10% of all mortalities. It accounts for approximately 5 million deaths each year and causes disability to millions more. About half of all deaths due to trauma are in people aged 15 to 45 years. Trauma is the leading cause of death in this age group. Death from injury is twice as common in males, especially in relation to motor vehicle accidents and interpersonal violence. Trauma is therefore a serious public health problem with significant social and economic costs. Significant variation exists in the causes and the effect of traumatic injuries between geographical areas and between low, middle, and high income countries. It should be noted that alcohol and drug abuse increase the rate of traumatic injuries by precipitating interpersonal violence, child and sexual abuse, and motor vehicle accidents. Traumatic injuries are classified by the World Health Organization into intentional, means either interpersonal violence related, war related, or self-inflicted injuries. And unintentional injuries, mainly motor vehicle accidents, falls, and other domestic accidents. Intentional trauma accounts for approximately half of the trauma-related deaths worldwide. A specific type of unintentional injury is iatrogenic injury, which occurs during therapeutic or diagnostic procedures by healthcare person. Traumatic insult are classified according to the basic mechanism of the injury into penetrating, when an object pierces the skin, and blunt injuries. Penetrating trauma is further classified according to the velocity of the projectile into high velocity projectiles, medium velocity projectiles, and low velocity items. High velocity 100 to 1000 meter per second. Medium velocity projectiles is hand gun bullet 200 to 300 meter per second, and low velocity items is knife steel. High velocity weapons inflict greater damage due to a temporarily expensive cavitation that causes destruction in a much larger area than the projectile tract itself. And low velocity injuries, the damage is usually confined to the projectile tract. Blast injury is a complex cause of trauma which includes blunt and penetrating trauma and burns. The most commonly used classification grading system is the AAST, which means American Association for the Study of Trauma Injury Scoring Scale. It is used for managing renal trauma, but for the other urological organs, the injuries are commonly described by their anatomical chart in severity, partial or complete. With general management principle, the initial emergency assessment of a trauma patient is beyond the focus of these guidelines. It is usually carried out by emergency medicine and trauma specialized personnel following ATLS principle. Detailed further assessment involves cross-sectional imaging, laboratory analysis, and specialist surgical input. The management of individual organ injury will follow in the sections below. Tetanus vaccine status should be assessed for all pediatric injuries. Polytrauma managed and major trauma centers lead to improved survival. Urological trauma is often associated with significant injuries in the polytraumatized patient. Lessons from civilian trauma, network, military conflict, and mass casualty events have led to many advances in trauma care. These include the widespread acceptance of damage control principles and trauma centralization to major trauma centers staffed by dedicated trauma teams. The organization of care to these centers has been shown to reduce mortality by 25% and length of stay by 4 days. Urologists increasingly understand their role in the context of polytrauma with the ultimate aims of improving survivability and decreasing morbidity in these patients. Damage control. Damage control is a life-saving strategy for a severely injured patient that recognizes the consequences of the lethal threat of trauma, hypothermia, coagulopathy, and acidosis. The first of three phased approach consists of rapid control of hemorrhage and water contamination. The second phase involves resuscitation in the intensive care unit with the goal of restoring normal temperature, coagulation, and tissue oxygenation. The final stage involves definitive surgery when more time consuming reconstructive procedures are performed in the stabilized patient. Urological intervention needs to be mindful of the phase of management. Temporary abbreviated measures followed by later definitive surgery are required. Complex reconstructive procedures, including organ preservation, are not undertaken. The decision to enter damage control mode is taken by the lead trauma clinician following team discussion. Urological examples include hemodynamically unstable patients due to suspected renal hemorrhage or pelvic fracture with exerted urethral or bladder injury. The options of abdominal packing and temporary renal drainage by urethral, bladder, or urethral catheterization are valuable adjuncts to care. Mass casualty events and triage. A mass casualty event is one in which the number of injured people and the severity of their injuries exceed the capability of the faculty and staff. Triage, communication, and preparedness are important components for a successful response. Triage after mass casualty events involves difficult moral and ethical considerations. Disaster triage requires differentiation of the few critically injured individuals who can be saved by immediate intervention from the many others with non-life-threatening injuries for whom treatment can be delayed and from those whose injuries are so severe that survival is unlikely in these circumstances. The role of thromboprophylaxis and bed rest. Trauma patients are at high risk of DVT. Concerns with regard to secondary hemorrhage result in prolonged bed rest post-injury, which effectively compounds this risk. Established prophylaxis measures reduces thrombosis and are recommended following system review. However, the strength of evidence is not high, and as yet there is no evidence to suggest that mortality or pulmonary embolism risk is reduced. Compression stockings and low molecular weight heparin are favored. The risks of secondary hemorrhage is uh, thought to be low, and practice of stacked bed rest as well in patients who are able to mobilize. Antibiotic stewardship. Single shot antibiotic doses are common in major trauma. The indication for continuing antibiotics is governed by injury grade, associated injury, and the need for intervention. Patients with urinary extravasation tend to be kept on antibiotic, but there is no evidence base for this. Antibiotics should be avoided in lesser trauma. Example, grade 1 to 3 renal trauma, and regular review undertaken for those continued on regular dosing. Urinary catheterization. Prolonged catheterization is required in all forms of bladder and urethral injury. Catheterization is not necessary in stable patients with low-grade renal injury. Patients with heavy hematuria who require monitoring or ureteric stenting benefit from catheterization. This can be removed once hematuria lightens and there is an improvement in the clinical situation. The shortest possible period of catheterization is advised. And now we will come to the urethral trauma. Epidemiology, etiology, and pathophysiology. Anterior male urethral injury. The bulbar urethra is the most common site affected by blunt trauma. In bulbar injury, the bulb is compressed against the pubic symphysis, resulting in rupture of the urethra at the site of compression. Possible mechanisms are straddle injuries or kicks to the perineum. A penile fracture can be complicated by the urethral injury in approximately 15% of cases. Penetrating anterior injury are rare and are usually caused by gunshot wounds, stab wounds, also dog bites, impalement, or penile amputation. Depending on the affected segment, penetrating injuries are usually associated with penile, testicular, and or pelvic injuries. Insertion of foreign bodies is another rare cause of anterior injury. It is usually a result of autoerotic stimulation or may be associated with psychiatric disorders. Iatrogenic injury is the most common type of urethral trauma. The incidence of urethral injury during transurethral catheterization is 6.7 per 1,000 catheters inserted and can occur due to creation of a false passage by the tip of the catheter in Edward and inflection of the enforing balloon in the urethra or removal of the catheter with the enforing.
Dr. Jamal? Dr. Jamal? डॉक्टर जमाल आपको मेरी बात आ रही
not only the application for every unit. जी sir.
जी प्लीज कंटिन्यू कर.
Sorry sir, internet.
जी जी कंटिन्यू करें कंटिन्यू.
A state indication for every urethral catheterization is an important preventive measures. The importance of catheter insertion training programs to prevent urethral injury during transurethral catheterization have been demonstrated. Preliminary data suggests that guide wire-led catheter insertion are use of a safety valve for balloon inflation may prevent urethral trauma and difficult catheterization cases. Instrumentation of the urethra, EURP, cystoscopy, etc. can traumatize all segments of it. During penile prosthesis insertion, the risk of urethral perforation is 0.1 to 4%. Proximal urethral angio are more common than distal ones. Now we come to posterior main urethral injuries. Blunt posterior urethral injury are almost exclusively related to pelvic fractures with disruption of the pelvic ring. These injuries are referred to as pelvic fracture urethral injuries and are mainly caused by motor vehicle accidents. Pelvic fracture urethral injury are divided into partial or complete ruptures. In complete ruptures, there is a gap between the disrupted ends of the urethra, which fills up with scar tissue. There is no urethral wall in the scared space, and any lumen presents a fistulous tract between the urethral stumps. Injuries of the bladder, neck, and prostate are rare and mostly occur at the anterior midline of both the bladder, neck, and prostatic urethra. It is highly uncommon to find a complete transection of the bladder, neck, or an avulsion of the interior part of the prostate. Concomitant injuries to the head, thorax, abdomen, and or spine are frequent, up to 66%. Penetrating injuries of the pelvis, perineum, or buttocks, mainly gunshot wounds, can also damage the posterior urethra but are extremely rare in the civilian setting. There is a high probability of associated injuries, 80 to 90%, mainly intra-abdominal. The associated injuries, which occur with both blunt and penetrating posterior urethral injuries, can be life-threatening, and if so, will govern the patient's assessment and treatment. Delayed morbidities of posterior urethral injuries include strictures, incontinence, and erectile dysfunction, all of which may have a detrimental effect on the patient quality of life. The pooled estimate for the proportion of patients with erectile dysfunction following pelvic
जी
It's sounding very.
डॉक्टर जमान ने
Sorry, sir.
Right.
Disconnection, internet call.
Correct. No problem. Please continue.
Female urethral injuries. Birth-related injuries to the female urethra are rare and consist of minor periurethral lacerations during vaginal delivery. Pelvic fractures are the main cause of blunt trauma. However, pelvic fracture injuries in females are rare and less common than in males. This is usually attributed to the flexibility provided by the vagina and the greater inherent elasticity of the female urethra. It may also be the result of less severe and more frequent stable pelvic fractures in females. In unstable pelvic fractures in females, a high suspicion for a urethral injury should be maintained. Female urethral injury are classified into two types: longitudinal or partial, most frequent injuries, and transverse or complete injuries. Concomitant bladder or vaginal injury is possible, therefore, females are at risk of developing urinary incontinence and urethrovaginal fistula. Insertion of a synthetic suburethral sling for the treatment of female stress urinary incontinence is complicated by an intraoperative urethral injury in 0.2 to 2.5% of cases and is an important cause of iatrogenic urethral injury. Evaluation of urethral trauma, clinical signs. Blood at the meatus is the cardinal sign, but the absence of it doesn't rule out a urethral injury. Inability to void means with a palpable distended bladder is another classic sign and is often associated with a complete rupture. Hematuria and pain on urination may be present in incomplete ruptures. Urinary extravasation and bleeding may result in scrotal, penile, and or perineal swelling in ecchymosis, depending on the location and extent of the trauma. The presentation of these clinical symptoms may be delayed more than 1 hour. Rectal examination should always be done to exclude unassociated rectal injury up to 5% of cases and may reveal a high riding prostate, which is an unreliable finding. Failure to detect a rectal injury can cause significant morbidity and even mortality. A rectal injury is suggested by blood on the examining finger and or a palpable laceration. Another sign of urethral injury is difficulty or inability to pass a urethral catheter. A female urethral injury should be suspected from the combination of unstable pelvic fracture with blood at the vaginal introitus, vaginal laceration, hematuria, urethroregia, labial swelling, urinary retention, or difficulties passing a urethral catheter. Vaginal examination is indicated to assess vaginal lacerations. Urethroplasty. Retrograde urethroplasty is the standard in the early evaluation of a male urethral injury and is conducted by injecting 20 to 30 ml of contrast material while occluding the meatus. Films should be taken in a 30-degree oblique position. In patients with pelvic fracture urethral injuries, it is important to move the X-ray beam to the 30% angle rather than the patient. In an unstable patient, RUG should be postponed until the patient has been stabilized. During RUG, any extravasation outside the urethra, pathognomic for urethral injury. A typical image for incomplete rupture shows extravasation from the urethra, which occurs while the bladder is still filling. A complete rupture is suggested by massive extravasation without bladder filling. Although RUG is able to reliably identify the site of injury, anterior versus posterior. The distinction between a complete and partial rupture is not all the way clear. Therefore, any proposed classification system based on RUG is not reliable. In females, The short urethra and vulvar edema makes adequate urethrography nearly impossible. Prior to deferred treatment, a combination of RUT and together evaluate the cysto-uretroscopy. Flexible cysto-uretroscopy is a valuable alternative to diagnose an acute urethral injury and may distinguish between complete and partial rupture. Is in suspected penile urology is associated with a heart. The short urethra often precludes adequate radiological visualization. Cysto-uretroscopy and vaginoscopy are the diagnostic modalities of choice. If prior to deferred treatment, the competence of the bladder neck is not clear up to integrate cysto-urethrography, isopropubic cystoscopy is advised. Ultrasound and MRI. In the acute phase, ultrasound scanning is used for guiding the placement of suprapubic catheter. In complex pelvic fracture urethral injuries, MRI before deferred treatment provides valuable additional information which can help to determine the most appropriate surgical strategy. This information includes a better estimation of the length of the destruction defect, degree of prostatic displacement, and presence or absence of a false spacing. Now we come to the disease management. Male anterior urethral injuries, immediate exploration and urethral reconstruction. This is indicated for penile fracture related injuries and non-life-threatening penetrating injuries. Small lacerations can be repaired by simple closure. Complete ruptures without extensive tissue loss are treated with anastomotic repair. In the case of longer defects of apparent infection, means particular bite wounds, a stage repair with urethral marsupialization is needed. Penetrating injuries require peri and post-operative antibiotic treatment. The role of immediate urethroplasty in blunt injuries is controversial. Patients 18.3% complete ruptures who underwent immediate urethroplasty had a failure rate that was not significantly different compared to those who underwent delayed urethroplasty after initial suprapubic diversion, which is 11.7% versus 18.6%. Predictive is 0.71%. The time to spontaneous voiding was significantly shorter in the immediate urethroplasty group, 27 versus 192 days. A structure rate of 14.4% following immediate repair has been reported based on 23 studies with a total of 591 patients. An analysis of direct comparative studies showed a composite structure rate of 20% for immediate repair versus 44.2% for early endoscopic realignment, but at the expense of longer hospital stay and increased blood loss. Perforation of the distal urethra during penile prosthesis insertion needs to be repaired over a catheter. In this instance, the initial procedure should be abandoned. Now we come to the urinary diversion. Blunt anterior urethral injuries are associated with spongiosal contusion. Evaluation of the limits of urethral debridement in the acute phase might be difficult in us. A consequence, it is reasonable to start with urinary diversion only. If urinary diversion is performed, the therapeutic options are suprapupal diversion or a trade-off early endoscopic realignment with transurethral catheterization. There is conflicting evidence as to which intervention is superior. Urinary diversion is maintained for 1 to 2 weeks for partial ruptures and 3 weeks for complete ruptures. Satisfactory canalization may occur in up to 68% after partial ruptures, 14% portrait for endoscopic realignment of blunt anterior entries. The wide range in success rate most likely reflects a mix of partial and complete ruptures, which was not further specified in the review. Transurethral or suprapubic urethral diversion are treatment option for iatrogenic or life-threatening penetrating injuries. Minor iatrogenic urethral injury and urethral contusion do not require a urinary diversion. And now we come to the male posterior urethral injury. Management of male posterior urethral injuries, emergency room management. As these injuries are usually associated with other severe injuries, resuscitation and immediate treatment of life-threatening injuries have absolute priority. Penetrating injuries, especially, have a very high likelihood of associated injuries requiring immediate exploration. There is no urgency to treat the urethral injury, and urinary diversion is not essential during the first hour after trauma. However, it is preferable to establish early urinary diversion to monitor urinary output, since this is a variable sign of the hemodynamic condition and the renal function of the patient. Treat symptomatic retention if the patient is still conscious. Minimize urinary extravasation and its secondary effects such as infection and fibrosis. Insertion of the suprapubic catheter is an accepted practice in urgent situations. However, insertion of a suprapubic catheter is not without risk, especially in the unstable trauma patient where the bladder is often displaced by a pelvic hematoma or because of poor bladder filling due to hemodynamic shock or concomitant bladder injury. In these circumstances, an attempt at urethral catheterization can be carried out by experienced personnel. It is extremely unlikely that the gentle passage of a urethral catheter will do any additional damage. Early urethral management, which is less than 6 weeks after injury. For partial injuries, urinary diversion means suprapubic or transurethral is sufficient, as these injuries can heal without significant scarring or obstruction. A complete injury will not heal, and formation of an obliterated segment is inevitable in case of suprapubic diversion alone. To avoid this obliteration in a long period of suprapubic diversion followed by deferred urethroplasty, the urethral ends can be sutured urethroplasty or approximated over a transurethral realignment. Immediate urethroplasty. Urethroplasty within 48 hours after injury is difficult because of poor visualization and the inability to accurately assess the degree of urethral destruction due to extensive swelling and ecchymosis, which may result in extensive unjustified urethral debridement. Another problem is the risk of severe bleeding, average is 3 liter following entry into the pelvic hematoma. In addition, with high rates of impotence, 23%, incontinence is 14%, and strictures is 54%. Urethroplasty within 48 hours is not indicated. Early urethroplasty. Urethroplasty can be performed after 2 days and up to 6 weeks after the initial injury. If associated injuries have been stabilized, the destruction defect is short, the perineum is soft, and the patient is able to lie down in the lethargic position. This avoids a long period of suprapubic diversion with its discomfort and complication. As the result, complications, structure recurrence, incontinence, and impotence are equivalent to delayed urethroplasty. Early urethroplasty might be option for patient fulfilling the above mentioned criteria. Lacerations, blood are penetrating at the bladder neck and prostatic urethra are a specific entity. They will never heal spontaneously, will cause local cavitation, presenting a source of infection, and compromise the intrinsic sphincter mechanism with increased risk of urinary incontinence. They must be reconstructed as soon as possible. For penetrating injuries with severe lesion to the prostate, prostatectomy, bladder neck sparing must be performed. Early realignment. Early realignment can be performed when a stable patient is on the operating table for other surgery or as a stand-alone procedure in the absence of concomitant injuries. In a partial injury, realignment and transurethral catheterization avoid extravasation of urine and the surrounding tissue, reducing the inflammatory response. In complete injuries, the aim of realignment is to correct severe destruction injuries rather than to prevent a structure. Realignment can be done by an open or endoscopic technique. The open technique is associated with longer operation times, more blood loss, and longer hospital stay. As such, endoscopic realignment is now preferred. Using a flexible or rigid cystoscope and biplanar fluoroscopy, a guide wire is placed inside the bladder under direct visual control. Over this, a catheter is placed. If necessary, two cystoscopes can be used. One retrograde means per urethra and one antegrade suprapubic route to the bladder neck. The duration of catheterization is 3 weeks for partial and 6 weeks for complete ruptures, with widening urethrography upon catheter removal. It is important to avoid traction on the balloon catheter as it can damage the remaining sphincter mechanism at the bladder neck. With the contemporary endoscopic realignment procedures, structure formation is reduced to 44 to 49% compared to 89 to 94%. Structure rate with suprapubic diversion. There is no evidence that early realignment increases the risk of urinary incontinence, which means 4.7 to 5.8%, or erectile dysfunction 16.7 to 20.5%. Another potential benefit of early realignment is that when a structure occurs, it will be shorter and therefore easier to treat. For short, non-obliterative structures following realignment, direct vision urethrotomy can be performed. Approximately 50% of structures after endoscopic realignment can be treated endoscopically. However, repetitive endoscopic procedures in case of structure formation might delay the time to definitive cure and can increase the incidence of adverse events, false passage, and abscess formation. In light of this, repetitive endoscopic treatment after failed realignment are not recommended. Urethroplasty must be performed. Coratum et al. Found a shorter structure length after early open realignment and as a consequence a tendency for less complex maneuvers to be needed to allow for tension-free anastomosis during urethroplasty. On the other hand, Tusk et al. Reported an equal structure length and no greater facilitation of urethroplasty after failed endoscopic alignment compared to suprapubic diversion only. The proposed benefit is thus highly questionable. Furthermore, there is conflicting evidence as to whether failed early realignment jeopardizes the success of definitive erythroplasty. Differences between series and the rates of incontinence, impotence, and restructure can be explained by differences in patient selection, severe versus less severe trauma, a mix of partial and complete ruptures, and differences in follow-up duration. Furthermore, these differences make the comparison with other techniques difficult, especially with urethroplasty. Deformity in the case of a complete rupture treated with an initial period of 3 months, suprapubic diversion, obliteration on the posterior urethra is almost inevitable. Endoscopic treatment of a complete obliteration is not successful. After at least 3 months of suprapubic diversion, the pelvic hematoma is nearly always resolved. The prostate has descended into a more normal position. The body is clinically stable and able to lie down in the starting position. Associated life-threatening injuries often preclude early management of penetrating membranous urethral injuries. In those cases, suprapubic diversion with delayed erythroplasty is also advised. Perineal anastomotic repair is the surgical technique of choice, but a combined abdominoperineal approach is necessary in rare cases of concomitant bladder neck injury or rectourethral fistula. The overall success rate for deferred erythroplasty is 86%. Deferred erythroplasty does not significantly affect erectile function. Although a small proportion, less than 7% of patients report de novo erectile dysfunction after delayed erythroplasty, others 6 to 20% have recovery of erectile dysfunction after delayed erythroplasty. Incontinence is rare with deferred erythroplasty, approximately 5%, and is usually due to incompetence of the bladder neck. The assessment of sexual function and the decision on definitive treatment, example penile prosthesis, should be undertaken 2 years after the trauma because of the potential returns of potency within that time. Now we come to the female urethral injuries. Emergency room management of pelvic rupture urethral injuries in females is the same as in males. Section, however, sequent management differs. Treatment option are early repair less than or equal to 7 days. Complication rate is the lowest with early repair. Therefore, this strategy is preferred once the patient is hemodynamically stable. Delayed repair greater than 7 days. Delayed repair often requires complex abdominal or combined abdominal vaginal reconstruction with elevated risk of urinary incontinence and vaginal stenosis. The approach, vaginal, abdominal, or combined for early repair depends on the location of the injury. Proximal and mid-urethral disruptions require immediate exploration and primary repair using the retropubic and transvaginal routes, respectively, with primary suturing of the urethral ends or urethral laceration. Concomitant vaginal laceration are repaired two-layer closure transvaginally at the same time. Distal urethral injury can be left hypospadic since they do not disrupt the sphincter mechanism, but a concomitant vaginal laceration must be closed. In a case of urethral injury during synthetic suburethral sling insertion, immediate repair is warranted with a portion of sling insertion. This is the complication rate for different treatment strategy for pelvic fracture urethral injuries in females. Type of repair, early alignment, early repair, and delayed repair. And this is summary of evidence of recommendation and evaluation and management of urethral trauma. And this is the summary of evidence. Implementing training programs on urinary catheter insertion for person involved in urethral catheterization significantly improve the rate of catheter-related complication. In males, a urethral injury is detected as contrast extravasation during urethroplasty or as mucosal laceration during cystourethroplasty, as opposed to cystourethroplasty. Widening cystourethroplasty will miss a female urethral injury in approximately 50% of cases. Transurethral or suprapubic urinary diversion are the treatment option for atherogenic injuries. Complete blunt anterior urethral ruptures are unlikely to be fixed by urinary diversion alone, whereas immediate urethroplasty has an equal success rate compared to delayed urethroplasty. And pelvic fracture urethral injuries are associated with life-threatening injuries. Urethral management has no priority and urinary diversion with either urethral or suprapubic catheterization is sufficient initially. With early endoscopic realignment, the structure rate is reduced to 44 to 49% with increased risk of incontinence or erectile dysfunction. Repetitive endoscopic treatment after failed realignment delayed the time of definitive cure and increased the incidence of adverse events. For partial posterior injuries, urinary diversion, suprapubic or transurethral is sufficient as these injuries might heal without significant scarring or obstruction. Immediate urethroplasty less than 48 hours in male pelvic fracture urethral injury is associated with a higher risk of bleeding and structure, incontinence and impotence rate compared to delayed urethroplasty. In selected patients for male pelvic fracture urethral injury, early urethroplasty 2 days to 6 weeks is associated with similar structure, incontinence and impotence rates compared to delayed urethroplasty. Suprapubic divergence with delayed urethroplasty in male, pelvic fracture urethral injury with complete urethral disruption and associated with 86% structure free success rate and with no significant impact on erectile function and urinary incontinence. Early repair in female pelvic fracture urethral injury has the lowest complication rate. And this is recommendation and strength rating. Recommendations: provide appropriate training to reduce the risk of traumatic catheterization. The strength rating is strong. And evaluate male urethral injury with flexible cystourethroplasty and or retrourethroplasty, and the strength rating also is strong. Evaluate female urethral injury with cystourethroplasty and vaginoscopy, and this strength rating is also strong. Treat iatrogenic anterior urethral injury by transurethral or suprapubic urinary diversion. This is also strong. Treat partial blunt anterior urethral injuries by suprapubic or urethral catheterization. Treat complete blunt anterior urethral injuries in males by immediate urethroplasty. The strength rating is weak. Treat pelvic fracture urethral injuries in hemodynamically unstable patients by transurethral or suprapubic catheterization initially. The strength rating is strong. Perform early endoscopic realignment in male pelvic fracture urethral injuries when feasible. This is weak. Do not repeat endoscopic treatment after failed realignment for male pelvic fracture urethral injuries. The strength rating is strong. Treat partial posterior urethral injuries initially by suprapubic or transurethral catheter. Do not perform immediate urethroplasty less than 48 hours in males pelvic fracture urethral injuries. The strength rating is strong. Perform early urethroplasty 2 days to 6 weeks for male pelvic fracture urethral injuries with complete disruption and selected patients stable short gap soft perineum lithotomy position possible. In this state, the strength rating is weak. Manage complete posterior urethral disruption in male pelvic fracture urethral injuries with suprapubic diversion and deferred mean at least 3 months. Urethroplasty is strong. Perform early repair means within 7 days. For female pelvic fracture urethral injuries, not delayed repair or early realignment, and the strength rating is strong. And now we come to the algorithm for management of anterior urethral injury in men. Anterior urethral injury, this is the types of injury: iatrogenic, blunt, penetrating penile fracture. If the injury is iatrogenic, we will go for the urinary diversion, urethral or suprapubic catheter. And if the injury is blunt, we will see is it partial or complete. If partial, we will go for urinary diversion, and if complete, we will go for immediate repair. And if the injury is penetrating, we will see to the patient is it stable or not. If yes, we will go for immediate repair. If no, we will go for urinary diversion, urethral or suprapubic catheter. After urinary diversion, we will see partial for 1 to 2 weeks and complete for 3 weeks. After that, we will go for urethrogram and then follow up. Then in penile fracture, In the penile fracture, we will go for immediate repair and urethral diversion, urethral or suprapubic catheter 2 to 3 weeks. Now we come to the management of posterior urethral injury in men. Men posterior urethral injury, assess hemodynamic status. If the hemodynamic status is unstable, we will go for resuscitation plus urinary diversion and urethral catheter 1 attempt. If it is failed, then we'll go for suprapubic catheter. And if the hemodynamical status of patient is stable, then we will perform RUG or urethroscopy. And then we will see their partial injury or complete injury. If partial injury, we will go for early endoscopic realignment. If early endoscopic realignment is failed, then we will go for suprapubic catheter. And after that, follow-up. And after follow-up structure short, flimsy and non-obliterative. If yes, we will go for one direct visual internal urethrotomy. If it is failed, then we will go for delayed urethroplasty. And if the injury, the complete injury in the urethroskopy, we will see the complete injury. We will go for injury to we will see the injury to bladder neck and or prostate. If injury is present in the bladder neck or prostate, we will early repair and follow up. And if no, we will go for surgery for associated injuries. If surgery for associated injuries, yes, we will go for early endoscopic alignment. If early endoscopic realignment is failed, we will go for suprapubic catheter. Suprapubic catheter will assess 2 days to 6 weeks, and we will see short distension defect, soft peritoneum, lethargic position possible. If these is able, if yes, we will go for early urethroplasty, and if no, we will go for a delayed urethroplasty also. Is more than 3 months, and this was the algorithm. Thank you.
Thank you very much. The last two slides are very important, and it summarizes the whole thing. And if you understand these two algorithms, the anterior urethral injury and the posterior urethral injury in men, I think this is what can be summarized, what has been written in the slide on the recommendations. So all the recommendations are put into this kind of flow chart. So yes, Rafi, you want to say something?
The algorithm shows that one attempt should be given in urethral catheterization. I had the perception that urethral catheterization would do more harm if there is a posterior urethral injury. Is that the case, or
Yes, it is the
we
case.
should directly go?
No, it is the case, and whenever this thing is written, it is always written that you must attempt gently. Now, there is no measurement of gentleness. I can say that, for instance, if my hand is gentle, then it is gentle according to my own perception. So nobody can tell anybody else that your attempt is a gentle attempt and it should be done. So by all means, what the actual practice is that one should not attempt catheterization when there is a history of trauma to the pelvis. There is a bleb of blood at the external urethral meatus. There is not much that can be gained with a catheter from down up, but there is a lot that can be gained if you do know how to do a proper suprapubic cystostomy. It is very easy to do, and it is very effective in managing the patient afterwards. So there are, if you know how to do it properly under the guidance of ultrasound, then it is something of benefit to the patient. Why I am telling you that it should be done under ultrasound guidance is because whenever there is a pelvic injury or pubic bone injury, for instance, in a male person, there is some sort of uh, implication or trauma to the puboprostatic ligaments. If that is done or that is there, then what happens to the bladder is the bladder is taken up, meaning to say there is distraction in the form the bladder will not be present in its original position in the pelvis. It will rather be up, just maybe below the umbilicus. So you will find your bladder slightly up when there is an injury to the pubic bone. So it is better to do suprapubic cystostomy under the guidance of the ultrasound probe, so that your placement of catheter is proper. Otherwise, you will be going directly into the urethra, not into the bladder. Yes, somebody was asking something else. So anybody wants to say anything now, or we can just close everything? Right, okay. So thank you very much, both the presenters. It was an excellent session, a detailed session rather. Two new subjects that we have discussed. New in the sense that they are something of later stage when you have done your reading of probably the whole of urology. So we will be again referring to the same topics again and again in years to come. So till tomorrow, the office, we'll meet again.